of y'all just wanted to know how many of y'all are actually already doing rubber band ligation in your practice? Anyone?
Yes.
Okay. Is anyone not doing it?
There you go. You
Mm,
hate.
yes, but
Why?
I hate it. Okay.
I love it.
All right. So let's get started. So this is not by any means meant to be comprehensive. Mostly, I envision this to be an introduction to people who are not already doing it, but also to share ideas with people who are in the process of doing it currently. So, I mean, we all know the statistics, pretty prevalent problem, 4.4%. So that's millions of people, peak prevalence in the Middle Ages. And very importantly, only one third of these folks actually seek any kind of medical help. I mean, we do screening colonoscopies all the time, and we see a lot of enlarged internal hemorrhoids. And then when you actually start asking these patients at the follow-up visit or maybe right after the procedure, if they have any kind of symptoms, you'll be surprised that a lot of them actually do. Um, just quickly go over the anatomy here. You can see, is my cursor showing up?
Yes, it is.
Okay, so you can see the internal hemorrhoidal plexus here. This is the dentate line, and obviously very, very obvious where the dentate line is when we are in the rectum. So just above that would be the internal hemorrhoidal plexus and the external one further down below. This is when the internal hemorrhoids get enlarged, and you can see they start prolapsing into the anal canal. And that's when actually they start causing trouble with bleeding uh, and sometimes leakage, itching. Commonly, mucus can come out and irritate the perianal area. Some patients over the years, so I've been doing band ligation. It will be 10 years this coming April. And I have seen all kinds of symptoms, discomfort, bleeding, leaking, itching, tissue just protruding out. So just a quick overview, most of the symptoms, they actually come from enlarged internal hemorrhoids. Bleeding still remains the most common symptom. As I already mentioned, it could be some tissue prolapse as well. Interestingly, so this is from a review that was published in CGH back in 2019. They do mention here that hemorrhoids typically do not cause a positive hemoccult test because this, I think, issue comes up a lot um, when talking to patients who undergo hemoccult testing or now most recently FIT testing and Cologuard. And it does talk about the prolapsing tissue, how it can lead to some fecal soiling as well. Um, Grading of the hemorrhoids, grade 1 is where there's no prolapse. Grade 2, they prolapse during defecation, but they reduce spontaneously. Grade 3, when they have to be manually reduced. And grade 4, when they actually do not reduce. So this is all based on talking to the patients. This is not necessarily based on exam, although exam um, if you do just the exam without talking with the patients, a lot of the times you can tell, but not necessarily always. So again, when we are talking to the patients about their hemorrhoidal symptoms, it's important to grade them based on that because grade 4, if confirmed by examination, I won't even bother doing anything by myself, and those patients go to colorectal surgeons. In my experience, grade 1 and 2 respond very, very well to band ligation in the office. Grade 3, for the most part, does, but not always. Just a little schematic of a band ligator suctioning in the internal hemorrhoidal tissue and with the band getting deployed. want to play a little video here. Let's see. Sorry. So this is just a brief demonstration. Sorry, guys. Hold on. So this is from the company CRH. Okay, so that was just a little schematic of that. And let's see. Sorry, as you guys can tell, this is my first time actually presenting on Zoom, so pardon me for.
All I'm seeing is a white screen, nothing.
Oh, is that right?
Yeah, is anybody else seeing stuff? Are you guys all seeing stuff?
Did you guys
No.
not see the video?
Yeah, no, yeah, we're not seeing the video.
I'm sorry, the video did not show?
It did not. I did not see it.
Well, sorry about that. Mm, okay, give me 1 second. Okay, can you guys see the presentation, the PowerPoint slides back on?
Yes.
Okay. All right. Well, I mean, you guys have done the procedure, so it was just mostly like an introductory video. So I did want to go over for people who are not currently doing band ligation. So this is the code, the CPT code 46221, and this is the Medicare allowable from last year. I have to update that with the upcoming year. But as you can see, a procedure that takes maybe 5 minutes, the Medicare allowable is 282, and it's actually better than that for commercial insurances. The 46600 is the endoscopy code. Now, what I have seen over the years is uh, the insurance companies, especially the private payers, they don't necessarily want to pay for the endoscopy at the same time. So a lot of the times when you're considering doing band ligation, at that visit, it might be a good idea to do the endoscopy to get a better feel and look inside and see how the hemorrhoids look like. And also importantly, to rule out any anal fissures, which if present, will need treatment at the same time. Um, if you're treating anal fissures and you're prescribing medications for that, such as nitroglycerin ointment, you can also bill for an office visit code as well. I have done 99212 in the past, and then I tried 99213. It's variable as far as payment is concerned. So most recently, rather than dealing with rejections and all of that, when I'm doing band ligation, I've just simply started putting 46221 and that's it. So typically there are 3 sessions involved. I would say about 80 to 90% of patients, that's all they need. But sometimes you may need to do more. And again, really depends on their symptoms. So there is a global period for this. It's 10 days. So you got to make sure that the 2 sessions are at least 10 days apart. I typically do 2 weeks apart so that there's no confusion there. So I do 3 of these sessions over a course of 6 weeks or so, and then I give them a month, and then I see them back again to see how they're feeling. And if they're much improved but still having some symptoms, I'll probably go ahead and do a 4th session as well. One trick that I have learned over the years is, especially when you're doing the 4th session, you want to kind of like direct it towards whichever is the most prominent one or most prolapsing internal hemorrhoid. The trick to finding that out is, instead of directing the ligator towards one of the 3 positions, you direct it centrally and let the hemorrhoid that is prolapsing the most fall into that. And then once you have done that, then you obviously on the digital rectal exam can go in and find out which hemorrhoidal column it was. So hour by hour, this is probably the most profitable thing that you can do in your practice. I have never done that many, like I guess some maybe national experts might be doing. So in my practice, I have found that I end up doing maybe anywhere from 2 to 4 per week. How do you guys find the volume to be? Louis, how many do you end up doing?
Yeah, that's similar. I think maybe 2 a week,
Yeah.
thing like that. Now I do. I realize that it's not profitable, but usually I will do their first banding at the time of their colonoscopy, if I think they need it, because it saves them a session and saves them time and money, and they typically appreciate that. So I think it's better. I also typically put on 2 bands at a time. So I'll band 2 columns at a time in order to reduce the number of sessions for them, and I think get better results. So I don't operate in a manner that maximizes the financial aspect of it. That's what we do.
No, I mean that is good, but actually, there's that position, well, not position paper, but the opinion published in CGH, and also some other studies also showed that to minimize the complication risk, the best way is to only do 1 band per session.
Okay. Yeah, that's interesting.
Yeah. But this has come up in the past, and I have looked into that as well. And that's what I tell the patients. Sometimes there may be someone who would say, hey, I'm willing to take that risk. I want to do more than 1. And then I would go ahead and do it. I've done up to 3 in 1 session, but that's not necessarily what's advisable.
Sure.
Any
Anybody
questions so far, guys?
Yeah, Gaurav, quick question, Mr. Bharat here. So the 46221 is the anoscopy code. Are you doing anoscopy each time you're doing the bands, or
No, so 46221 is the band ligation code. The endoscopy
that's a
one,
band? Okay,
yeah, the second one. No, I'm not doing endoscopy each time. I just do it one time initially,
right,
either at the first session or before the first session. And
right.
if at the follow-up visit after 3 sessions, if they're still having any complaints, I sometime may do it at that time.
Yeah, that makes sense. Okay.
Have any of you guys used Easy Band yet?
That's what I'm using actually right now. I started off with CRH. Currently, I think they're selling it for 70 or 75 bucks per piece. Then, well, sorry, I'm not using Easy Bands currently. Then I went to Easy Bands, which was cheaper. But then the Hema Band, Snyder Hema Band came out, which actually has the obturator uh, for easy passage, which is similar to the second generation of CRH band ligators. So that's what I'm using right now.
I haven't heard of that company. What's it called? Goro?
Snyder Hema Band.
Standard Human. Okay.
Yeah, they were offering, I think if you buy in bulk, I believe I bought like 200 of these ligators. And I think it brought the price down to, if I remember correctly, 35 or 37 per ligator. So, I mean, all in all, this has been very useful for the patients. A lot of them have tried over-the-counter stuff, and for some of them it works, but when you find that they end up using the same stuff over and over again with not really much relief, I think this is a great procedure to offer to them, and definitely brings in more revenue to the practice too. David, are you doing it in your new practice yet?
We haven't we haven't started yet in this new practice.
Gotcha.
I mean, I think this whole thing has made us better doctors. I mean, I don't remember how many years I've been doing this, but I'm sure you can attest to that, Gaurav. I was not trained to do this in fellowship. And then, maybe 15, 18, 20 years ago, we were using varicose banders. And those, this is much better. It's much better. You're non-distending the rectum, and the retroflex position is not optimal for banding hemorrhoids. So I think this has been, and then just integrating anoscopy into our practice. I do a lot of anoscopy on physical exams. I don't know how many of y'all are doing those, but these same self-lighted anoscopes are quite useful in practice. Is everybody else using those a lot?
I have the basic anoscopes, but I also have the lighted, some of them, the lighted anoscopes as well.
I mean, they're only a few dollars each, I think, and so that you pull the little tab out, and it's a great little device, and it just improves your diagnostic capability on anorectal exams, and when you're and if you're following the Wakar Qureshi exam protocol, but I like, I use the same anoscopes. Now, one of the things that I just wanted to say is that, this is, I guess, just between us and all that kind of thing, but I think it's highly questionable whether or not you need to use a new device on the same patient every time. Have you ever discussed reusing it on that patient?
Like, what do you mean? Like the band ligator, just save it for the future?
Yeah, just cleaning it. You clean it and save it for that patient when they return.
I'm not sure if it is. I've never thought about it that way, but I'm not sure if it is worth uh, trying to save, 30-35 bucks for any kind of issues. I remember reading somewhere, I think this happened in New Jersey. There was a colorectal surgeon who was reusing the anorectal manometry catheter on different
Yeah.
patients after cleaning, obviously, but still. And he got into big time trouble.
Yeah, this what I'm talking about is I know that it's been done a number of times, and it's not using it on other patients. It's using it only on that same patient,
Right.
which is a different process. And as you know, this is a simple plastic device that is easy to clean.
So Louis, does a patient take it home and bring it back for their next banding session?
No, they just have it. We have a shelf, and we have a patient sticker on it, and it's cleaned with it's disinfected, and then just saved for them when they come back.
Hmm.
It's highly it's not something that everybody does or recommends, and CRH, of course, wants you to spend $70 every time they come back. But I don't understand the need to do that. I'm confused by the need to do that.
Vivian, you have a question?
Yeah, is anyone using just the regular ligators like surgeons use, where we can just like clean it through like a sanitizer machine, and then reuse it? Like, why are we like, I don't I don't understand. The colorectal surgeons ban, but they don't use this disposable system for the most part, or I could be mistaken. I would prefer like something where I can sanitize and then just buy the bands and apply.
Well, you just the device. These devices are thrown away. They're single-use devices. You don't have to sanitize anything.
Yes, I understand that, and I know that. But what I'm
Yeah.
saying is that aren't there other banders available that are not disposable that we actually like can use? Like, are there not other banding devices where we just replace the band but can sanitize the actual tool?
Here, let me show you something.
Other ligator systems?
Hold on.
Because do the colorectal surgeons use these CRH and Snyder options?
Is this what you're talking about, Vivian?
Yes.
I don't know how how this is in my office and where we got it from, but I've never used it. But it is there, and it is pretty straightforward. You can see there's a handle type of deal here, and this is where you apply the bandwidth. And yeah, I don't think that this one even needs to be attached to wall suction. Some of them are suction based. So yeah,
but not all. Yeah.
right. So then,
So
I mean, question would be how much it will cost you to sanitize.
well, yeah, I already have that kind of sanitizing equipment, so that doesn't cost a lot. So I was just wondering if anybody was using that protocol, because I would prefer to use that. And I've been doing banding for a long time. I use the Snyder right now. I don't feel like I feel like it's a 60-40. 60% of the time, the band works great. It's great. 40% of the time, I just don't feel like I get good results. And that kind of irks me a little bit. So I've learned the technique multiple times. I just don't feel I have consistent results when I just go in blindly. So that's why I hate doing it, because I like to do something where I'm like, works great, good, but I just don't feel like I confidently get those results every time. So I was wondering where, everyone else stands. And, in my circles, everyone kind of says the same thing. It's kind of like hit or miss, so where does everyone else stand on that? You feel like
Vivian,
advanced rate?
how much does it cost to set up the sanitization system?
Oh, I don't know. I just inherited a practice where they had a little office that had the sanitization system to sanitize used like, you know, surgical stuff, surgical equipment. I don't think it cost a lot. I
Okay.
can find out and share that, but I don't think it cost a lot.
And how many do you end up doing, like on a weekly basis or monthly basis?
I actually do 4 to 6 per week. I have a hemorrhoid clinic on Wednesday mornings. Tomorrow it's coming up. And I do about 4 to 6.
Okay.
I also see a lot of women, right? A lot of women have hemorrhoid issues. So I wonder if there's a slight difference in maybe the position of a retrovirted uterus and the position of, you know, maybe having women with rectal seals where it's harder to actually get that tissue or there's spacing there. But I mean, I don't feel super confident, even in spite of all the years and the number I do, that I always consistently get good results, you know?
What do you mean by that good results? Like, how do you define a good result? Do you mean enough tissue in there that is not too tight?
Yeah. I think enough tissue, and where the patient comes back 3 months later or 2 months later and is like, worked absolutely great, wonderful.
So you mean they come back and they say they're bleeding just as much?
Some of them are bleeding less, but I still feel like they still have little symptoms.
You know, that I think that may be the issue, is that almost all my bandings, obviously listen to Gaurav, almost all the bandings that I do are for bleeding. And I mean, I find that it's a very effective for bleeding. And you know, patients, I do think it's much less effective for pruritus and for other symptoms like that. But I find and sometimes, you know, so I've seen it effective for that. But I explain to the patient, if that's the issue, I explain to them it's much less effective. But there's a chance it'll work. And so, but in terms of bleeding, I find it. I don't know, Gaurav, what do you think?
I completely agree with you. I think in that order, bleeding, and then tissue protrusion, then pruritus, and then soiling. I think in that order, the effectiveness goes down. But again, I mean, you know, options wise, you know, as long as they understand that, you know, I mean, there's not a whole lot of other good options. Now, perianal pruritus, obviously, you always have to make sure when you're doing the exam that there's no tinea cruris going on. I find a lot of that. A lot of these patients actually end up using wet wipes, which just makes it worse. So I actually prescribe a lot of Lotrisone ointment to take care of these pruritus symptoms. And if with that, if it doesn't resolve, then we talk about doing banding.
So Vivian, does that help you at all, or do you still feel like bleeding is not improved in your practice?
I mean, I actually don't even do it on patients with itching, like pruritus. I don't feel like there's going to be that much benefit, you know? So I don't know that I always do it on someone who says I'm bleeding, and like I bleed sometimes, but you know, a lot of our women will come in and say, women, you know, it just, you know, the prolapse is usually the bigger issue, you know, the sensation of fullness, not emptying, the leakage. Those are the main symptoms. Bleeding periodically, but if someone bleeds very intermittently, like once a month or once every, you know,
Yeah.
I don't know that I'll see. I think acute bleeding, like, oh, I'm bleeding a ton from my hemorrhoids, that's a wonderful time to band even right there and then. But I don't know if that's the bulk of my patients, you know.
Vivian, the
I don't
symptoms
offer,
sorry, the symptoms that you described sound like pelvic floor dyssynergia, outlet obstruction. So those patients may actually benefit from anorectal manometry.
Like leakage. Well, when I say leakage, it's not like incontinence. It's really like, you know, a lot of patients with hemorrhoids, especially when there's prolapse a little bit, feel like I kind of have to wipe a little bit because I feel like my hemorrhoids are prolapsing. I don't know that it's from pelvic floor. I mean, maybe. I think it's a good option for patients, but I just don't feel confident in the outcomes overall. You know, that could just be me, but that's over the years I have felt like it's not that great. It's okay. But it's great. I mean, it's generates revenue and everything, but it's not, you know.
No, I mean, but the revenue is not the primary concern, right? I mean, if we have something to offer the patients that can potentially save them from surgery and provides a kind of like better relief than just over-the-counter stuff that they can use, uh, I think that really is the primary thing here. And if in the process we are getting paid decently to do that, you know, that's just the icing on the cake.
Yeah. Yeah. No, but it was helpful to hear, you know, the patients who would benefit the most, right? I think that's helpful to hear and know the ones where your results may be so. Yeah.
Also, Gaurav, do you tell them, how long do you tell them to expect the, you know, I usually will tell patients this is a 2 to 5 year solution just to give them some idea. What do you tell people about the long term?
And pretty much the same thing. And actually, I also tell them, because this is a question that almost always comes up, what is the durability of benefit? And I tell them that studies have shown the durability to be similar between rubber band ligation and surgical hemorrhoidectomy. But time horizon wise, yeah, I tell them, you know, 2 to 5 years. Yeah, I tell them maybe in 3 years or so, you know, you may start experiencing. But very, very importantly, I go over the fact that, look, why did you get it in the first place? And you need to change that behavior if you want to avoid it again. So no excessive straining, no sitting on the toilet for too long, taking your phone in there. You need to add supplemental fiber to your diet if your diet is lacking in that. So all of those things, I counsel them on that. So they know that if they want to avoid needing all of this stuff again, they have to follow those instructions.
That's really good. I like that. Thank you.
And also one thing that I started doing several years ago was when doing the retroflexion in the rectum, doing a screening colonoscopy or something like that, once I have taken a good look, then I suction maybe half of the air back and take a look again in the distal rectum and the anorectal area to see if they have any internal hemorrhoids, because very, very commonly they will flatten out if the rectum is distended. And I think, Louis, you alluded to that earlier as well. But again, anoscopy probably is a better way of looking to see if someone has internal hemorrhoids. If anyone is not already doing band ligation, and if you're interested in actually starting that, the company CRH, they do have two surgeons who are the medical directors for the company. And that's how I got started, because, you know, again, same story with everyone. Fellowship, they don't really teach us, you know, anything much about hemorrhoids, and certainly not how to take care of them. So if you reach out to that company, very, very nice guys, Andy and Mitch. So I can share Andy's cell phone number if you're interested. And he will come by and all you have to do is get some patients lined up, and he will go through all of that. They send you videos and everything beforehand, and then he will help guide you as well. So pretty easy to get started. And definitely, as you start doing a decent number, you'll start getting a very good feel for patient selection and exactly how to um, go about that so as to maximize the benefit to the patients.
One quick question I was going to ask: do you guys ban on patients who are on blood thinners? I know when I spoke to Mitch about this, he didn't think it seemed to be a problem, or he mentioned some study that was done, but I was kind of curious what you guys do on that.
Samir, I have banded maybe about a dozen patients over the years on all kinds of blood thinners: Eliquis, Xarelto, Coumadin, Plavix, and thankfully none of them had any issues. I have only had one significant bleeding over the years. That patient actually needed to go to the ER, and that patient was not on any blood thinners. So, but the thing is, I think this is recommended as well. If a patient is on blood thinners, infrared coagulation is the recommended modality. So if you are not doing that, but if someone else is doing it in your area, I think the patient will be best served by sending the patient to that particular facility or person who can do that. So that's what I do now.
Perfect. Thank you.
Welcome. Has anyone done IRC or has the equipment? I know that Dr. Dasari inherited IRC equipment. She and I were talking about that yesterday. But has anyone done IRC?
Yeah, I did it about 20 years ago when I first started my practice, and I wasn't too impressed with that. I think I had better results with the CRH banding.
Oh, interesting. Okay.
Hey Gaurav, can you just say, did you say that you do banding on patients on anticoagulants? I haven't done that in my practice. Only aspirin doesn't matter to me, but anybody else, and antiplatelets or those Xareltos, I haven't been doing those patients. And you've had good success without complications on those patients?
Correct. And when I did do that, I did tell the patients that, look, this may result in higher risk of complications, chiefly bleeding. And only if they agreed to proceed, which pretty much they did, that's when I proceeded with that. And actually, they did just fine. So one of the arguments I remember discussing with Andy from CRH previously, the thing is, when you're doing the banding, the risk of bleeding is not there at that time. So the risk of bleeding would be when the band falls off, leaves behind that ulcer, the banding ulcer. That's when the risk of bleeding is there. So even if
Right.
you were gonna, let's say, stop the anticoagulant, you're probably best off stopping it. Let's say if it is one of these directly acting anticoagulants, you're better off stopping it on the day of the procedure, so that, like, day and a half later, it has cleared their system, and which is when the risk of bleeding starts to go up from the banding ulcer. So kind of like you really have to take into account their thromboembolic risk and judge it against their bleeding risk. But as I said, the ones that I didn't even stop their anticoagulants, and they did just fine.
We have stopped. We've been doing it for years on patients like that, and we stop it. And I think it's very good advice. You don't need to stop it beforehand. If they come in on it, you can stop it. But we get permission from their hematologist or from their cardiologist, and just get confirm that. And then, because a lot of those patients need banding. I mean, they're bleeding, and sometimes they're bleeding very frequently and sometimes severely. And so, but it has to be put into context of the risk. And so, but I agree with you. Typically, if they stop it, from that day, you're talking about an 8-day stop or something like that. So I don't know if that is, been objectively proven what time you can resume it. But I think that the biggest bleed I've seen was like 6 or 7 days after banding.
And this was a patient who was on anticoagulants?
Yeah, that's correct. They were on anticoagulants. And how long do you think, when do you think that ulceration is its highest risk of bleeding? Do you not think it's probably between 5 and 7 days, maybe, or longer? After the band, when do you think that risk is?
Because I'm not sure where the highest level of risk would be. But when I have had to, if someone came back with pain or something, and when I did the endoscopy, I definitely have seen ulceration starting like a couple of days after the procedure.
Yeah, I remember having this conversation in deep dive with Mitch, who's one of the surgeons that teaches at CRH. I think he was suggesting that the highest bleeding risk is at like a week in those circumstances, but I don't know.
Yeah, so that makes it really tough, right? Especially with the newer anticoagulants. I mean, if you stop it 2 days before, then when do you actually resume it?
Right. Again, you really have to. It has to be a strong indication and in context, of discussion with their cardiologist or hematologist or whatever.
Absolutely. And what I have done also is if someone is high risk for thromboembolic complications, I offer them to go see the surgeon too, so that they can get everything done in one setting after having stopped their anticoagulant. All right, very good, guys. Any other questions? Okay, well, thank you everyone for joining us tonight. As always, excellent discussion, and this is how we do it. We help each other, discuss with each other, and advance the independent practice of GI in Texas this way.
Great job, my friend. Thank you so much.
Thank you, Louis. Thank you everyone for attending.
Thank you.
Thank you.
Bye-bye.
Everyone, good night.
Good night.